Good morning and welcome to Quarantine University. Today we're going to be talking about a subject that's been an interest of mine for some time, looking at the pineal masses. This is an area where I find that more often we're dealing with variations in benign disease rather than malignancies. So I want you to be familiar with all of these variations. And we'll then talk about some of the malignant tumors that occur in the pineal region. And again, this is going to be primarily focusing on adults. Now, the pineal region masses that you're going to see frequently in lectures and in the literature, these are going to focus more on the children, where the germ cell tumors are the most common variation of tumor that you'll see. So germinomas are the most common type of tumor that you'll see in the pineal region in children. And next most common are the teratomas. And the teratomas have a little more heterogeneous appearance on MR than the germinomas. Now, when I talk about pineal region, I'm referring to a specific location in this high resolution imaging through the midline, where you can see the normal structures in the anterior third ventricle, a little piece of the thalamus here. This is the pineal gland. Now, the normal pineal gland lies at the posterior third ventricle, below the internal cerebral vein and vein of Galen. This is the splenium of the corpus callosum. This is the quadrigeminal plate, superior colliculus, inferior colliculus, aqueduct of Sylvius. Here you can see, this is the pineal. This is the posterior commissure. Posterior commissure is this C-shaped structure that lies just above the quadrigeminal plate. And then this vascular structure here, this is probably the precentral cerebellar vein, which courses between the collicular plate and the vermis and drains into the vein of Galen. It's one of the veins that drain into the vein of Galen, in addition to the inferior sagittal sinus and basal vein of Rosenthal. This location is characteristic, and again note the position of the pineal gland below the vein of Galen and internal cerebral veins. Now, this cystic structure here that you see again on high resolution imaging, this is not, in my opinion, a pineal region lesion. This is separate in terms of the differential, because this lesion lies above the internal cerebral veins, placing it, and if the fornix is elevated up, that puts this into the region of the velum interpositum. So again, learn this fine anatomy, and this will help you may decide in terms of the nature of the lesion exactly where the anatomic structure is that you're pursuing. Now, pineal masses are common in the adult, but these are frequently benign lesions. And these are, the most common lesion is the pineal cyst. And when we're talking about solid masses, we want to think in terms of primary pineal cell tumors, not so much the germ cell tumors, but pineocytoma, intermediate grade tumors, and pineoblastomas. Now, these can be, you can decide on these a little bit by their behavior. The pineoblastomas are much more likely to have metastatic lesions, carcinomatous meningitis, and the like. And these are usually larger solid tumors. Metastatic disease is something that you have to keep in mind. Remember that the pineal gland has no blood-brain barrier. So just like we sometimes see metastatic disease to the pineal, to the pituitary, I showed you a case of that not long ago, that metastatic disease to the pineal is also a consideration. Meningiomas, glial tumors also occur here. I'll show these to you, but I want you to be aware that sometimes it's hard to distinguish these. I think the most important question is whether you're dealing with benign or malignant disease. Pineal cysts are much more common in women. I think as high as 80% of pineal cysts that you're going to see are in women. If you, in your practice, as you see pineal cysts, look for this association. I think you'll find it's pretty reliable. These pineal cysts can vary in size and signal. They also occasionally will have fluid levels within them. And so don't get too alarmed about that when you see it and suggest it's something besides a pineal cyst. And their enhancing properties can be confusing because the normal pineal gland has no blood-brain barrier. And the story I remember, although I'm not sure I can been able to identify that in the literature, is that the first discovery of the blood-brain barrier was based on a pathologist sectioning the brain who noticed that in a patient who was jaundiced, and so sort of every tissue was yellow in this patient from their jaundice, they noticed that the brain was white and sort of pristine looking, while the pineal gland was yellow from the cirrhosis. And that was the first inclination that there was some barrier to the brain that was not present in the pineal gland. So again, this property of enhancement of the pineal can be confusing for patients. Now, in this individual, you'll notice that this is a calcified pineal gland, which is physiologic and normal in patients as they age. You'll also notice that the pineal gland, this normal pineal gland, lies below the vein of Galen internal cerebral veins and above the quadrigeminal plate here seen on this CT scan. These pineal cysts really have no known significance. They occur in both adults and in children. Remember that arachnoid cysts can also be evident in the pineal region. Now, while these arachnoid cysts are frequently called pineal cysts, you'll notice that in FLAIR imaging that the pineal cysts usually do not suppress, but the arachnoid cysts, of course, because they're filled with CSF, these do suppress on FLAIR imaging. Pineal cysts occur in about 4% of patients, again, most common in women. These are rarely symptomatic. These never progress to neoplasm, and large cysts can cause symptoms, but their symptoms are due to aqueductal compression, not from any intrinsic property of the pineal gland. This is a paper we did in 1986 where we were noticing these bright areas here in the pineal region. Notice the quality of the imaging in 1986 on these low field MR scanners. We've come a long way in that regard. But we noticed in about 4% of patients, we were seeing these cystic lesions in the pineal region. Now here's a patient. Now this appearance can be alarming to some individuals. Here you see on the sagittal FLAIR scan, you have, it looks like a mass in the pineal region below the internal cerebral veins. Again, some flattening of the collicular plate. It doesn't suppress on FLAIR imaging like the ventricles do here on this FLAIR scan. Shows peripheral enhancement. This is a normal appearance of a pineal cyst. This is not, this should not be an alarming lesion for you. Once you know that, this patient does not have hydrocephalus. If they have headaches, that's a little troublesome because many patients have pineal cysts and they have headaches, but for different reasons. So operating on a pineal cyst, I think, is a precarious decision in the sense of weighing risk and benefit. So again, normal pineal cyst. Now this is the only case I've seen in my career of a pineal cyst that led to hydrocephalus. This was a young woman, and you can, again, please mute your microphones. You'll see this pineal cyst in this location, again, beneath the internal cerebral vein. And you can see that the aqueduct is compressed in this location. The ventricles are dilated. You'll also notice on the T2 weighted scan that the cyst has a different signal intensity than the CSF surrounding it. This would be the massa intermedia. So that for an 18-year-old, of course, these are huge ventricles. And so this was a pineal cyst that led to an obstructive hydrocephalus and was drained, and the patient did quite well. Here's another patient. Here's a pineal cyst. Follow-up was suggested. This was in 2003. Here they are in 2006. Rather than the expectation, I think, was that this might increase over time, but you notice that it decreased in time. So this has been shown in the literature that these cysts vary in size over time, and so they can get larger, but they can also get smaller, as was the case here. So again, this is another variation of pineal cyst. Here's a different case. Here it is in 2004. Here it is in 2006. So again, decreased in size over time. These, again, do not follow CSF on FLAIR imaging. While they can be greater than a centimeter, they're almost never symptomatic in my experience. And there's no real reason to follow up pineal cysts once you've made that decision. Now, some radiologists, and I think this was established in the literature, that pineal cyst in theory could be a precursor to a low-grade neoplasm, a pineocytoma. Excuse me one second. Thank you very much. How are you today? Thanks for taking care of us. You too. The joys of Zoom conferencing. So many radiologists will suggest follow-up because of the concern that these cysts will turn into a low-grade neoplasm. When in doubt, just get some thin section imaging, and neoplasm is likely only if there's nodular enhancement. And that was addressed, I think, in this very nice paper talking specifically about this problem of can a pineocytoma mimic a pineal cyst, which again was published in the literature some years ago. And in their conclusion, they're pretty, and I like this also, they're pretty definitive. No truly cystic pineocytomas were identified. So all of the cases they had this property of nodular enhancement. So if you don't see nodular enhancement, don't be raising the question of a low-grade neoplasm. Now, in this unfortunate case, you can see that this is a complicated, here's a pineal cyst, less enhancement, a little internal structure. The question was raised that this could be a pineocytoma. This actually went on to biopsy. So if you look in the literature, you'll see many series actually are in biopsy-proven pineal cysts. And I hope as people's awareness and sophistication in terms of imaging of pineal cyst increases, that this need for biopsy will reduce as our capabilities with imaging expand. Now, in this case, you can see this is a calcified pineal gland with a cystic structure here. Patient has this imaging, kind of expected finding, doesn't suppress on FLAIR imaging, low signal intensity, but non-CSF like on T1 weighted imaging, obviously cystic on T2 weighted imaging, diffusion, nothing restricted there. Pretty good until we get to the enhanced portion of the study. Now, in the enhanced portion of the study, this looks like nodular enhancement. And so this patient, they recommended, I think there was a little concern about whether this was real, and I think rightly so. They recommended a follow-up scan. So the patient came back a year later. Now, this is what the scan was that was concerning. This is what the patient looked like a year later. Now, what happened in between? My presumption is that this contrast-enhanced scan was obtained after a few minutes after the injection of contrast. And what I think is happening is the gadolinium weeps from the wall of the pineal gland into the fluid in the pineal cyst, which gives you this central enhancing sort of illusion. When you acquire the imaging immediately after the injection of contrast, you get this thin rim of enhancement around the cyst. And this was a letter we published years ago. Look at this case. This was a patient at the time of the injection of contrast. This is an hour later, and it looks like a solid mass. So be aware of this. Here's another case. Here you see post-GAD, immediately post-after injection. We image the patient 10 minutes later. It looks like there's a nodule here. So if there's any question, bring the patient back and do rapid imaging of the pineal gland immediately after injection of contrast. And you will be trapped in these cases where, let's say, the scanner goes down, there's a problem with the patient's nauseated after injection. Whatever it is that causes a delay in imaging after injection of contrast can give you the mistaken impression that this is a nodular enhancing cyst. Now, how about high resolution imaging? We thought, well, maybe this will help us because, you know, obviously a cyst should look like a cyst, but if there's a solid portion of the tumor, maybe that will help us discriminate from a cyst from a low-grade neoplasm. This is what happened when we started using high resolution imaging. We found that a lot of pineal cysts had a lot of structure in them, that these are both pineal cysts but this was using 1 millimeter Fiesta or steady state free precession imaging, much like you use maybe for your internal auditory canal studies looking at the 7th and 8th nerves. Now, this is a paper we did on that. This is what you expect a pineal cyst to look like. This is also a pineal cyst, maybe not what we expected it to look like. So be careful. Many of these cysts, normal pineal cysts that on low resolution imaging look like simple cysts, are actually fairly complicated and septated on the imaging. And that, I think, accounts for the appearance that I showed you, that case that went to biopsy with the pineal cyst that probably didn't need to be biopsied. So if the cyst completely suppresses on flare, so here again, looks like a pineal cyst, completely suppresses on flare imaging, no rim enhancement, this is actually more likely to be an arachnoid cyst than a pineal cyst. Kind of a fine distinction. It doesn't really matter to the patient. They're both benign, but kind of a subtlety that I think you should be aware of. So again, probably an arachnoid cyst, not a pineal cyst. Other benign masses that occur in the pineal region, these are the lipoma. Here you see this short T1 relaxation mass, sort of follows subcutaneous fat. And here it is on the CT scan, no question here based on low attenuation. So this is a lipoma, probably called a quadrigeminal plate lipoma. This is another lipoma. This one here lies along the internal cerebral vein. This is a velum interpositum lipoma. But again, same disease or same entity, sort of a developmental abnormality of no significance. I think it's important to just recognize these for what they are. This patient more complicated lesion. This one has short T1 relaxation time, but looks more cystic here on the T2 weighted imaging. Here again is non-contrast T1, non-contrast T1. Here it is on a fat suppressed scan. Now, if these are true fatty elements, that really goes against the diagnosis of a dermoid and favors a teratoma. So I think that this one, this never went to biopsy. You notice no edema around it. This is somewhere in this family of dermoid or teratoma, but I just want you to make you aware of this variation of appearance. And this is in the family of things that you'll see in the pineal region. Here's another lesion that has some imaging characteristics on the T1 and post-contrast imaging that resembles an arachnoid cyst, but you notice that it doesn't suppress on the FLAIR scan, and it has restricted diffusion on the DWI imaging, see here. So this is actually, we think this is a pineal epidermoid. And these can occur in the midline. They're usually in the paracellar region, but again, it doesn't change the diagnosis. I think this is most likely to be an epidermoid. So these are all benign tumors that occur in the pineal region. Now, one other consideration, this patient actually had a pineal tumor that was radiated. This is what they looked like at the time of right after their XRT. This is what they look like 6 months later. This is a radiation-induced cavernoma. So these also occur in the region of the midbrain and pineal region. You should be aware of them. This is a case we just saw the last couple of months. This patient had this lesion, short T1 relaxation time in the pineal region with obstruction of the ventricles from compression of the aqueduct. This is what it looked like on the CT scan, kind of this high attenuation rim. In some respects, I thought resembled a thrombosed aneurysm, but all the vascular imaging was negative. This is what the patient looked like at the presentation with the hydrocephalus, fluid level in this space. This is what they look like 2 months later. So we decided to just follow the patient. Now you can see the more homogeneous T1 shortening and the dark hemosiderin ring. This is probably a hemorrhage into a cavernoma that resulted in hydrocephalus. And as the mass resolved, the aqueductal compression resolved, and the patient now is normal ventricular size without a shunt. So just something to be aware of is that pineal region cavernoma. So now that we've talked about some of the benign variations, let's talk a little bit about adult pineal tumors. In children, we mentioned that these are usually germ cell tumors. In adults, they're more likely to be tumors of pineal cell origin. These are the pineocytoma, which is a low-grade pineal cell tumor, pineoblastoma, which is a high-grade pineal cell tumor, and intermediate grade, or PPTD, which I think is pineal parenchymal intermediate tumors. But meningiomas, metastatic disease, and glial tumors, these are also considerations, and I find sometimes hard to distinguish. So here's a child with this complex pineal region tumor, cystic, solid, kind of extending back here along the vein of Galen. This is what they look like 2 months later. This is appearance of a pineal teratoma. This is what they look like after surgery. Here's a different tumor. Notice this one is more solid with a few cysts, not a lot of enhancement here, and some restriction. This is a, here it is on FLAIR imaging. This is a primitive neuroectodermal tumor. So again, these are children with pineal region tumors. Now this is an adult, we'll call him an adult at 25. Here we have a cystic and solidly enhancing tumor in the pineal region. She had no symptoms. This is presumed to be a pineocytoma. This is a different type of appearance. This is a more solid appearance. This went to biopsy. This was also a pineocytoma. So again, pineocytoma, these are low-grade pineal tumors that, again, these are arising directly from pineal cells. These are not germ cell line tumors. Now this one looks like a pineocytoma in my opinion. It has a cyst, solid nodule. This proved to be a pineal parenchymal tumor of intermediate differentiation. That's that intermediate grade tumor that I mentioned. So again, there's a spectrum of histologies. I think it's sort of a reasonable discrepancy between the imaging and the pathology. I'm not sure how we can be that specific about the nature of these tumors. But again, this is in this family of low-grade pineal cell tumors. Now this tumor here, you can see this is a cystic pineal region tumor with some nodular enhancement. This proved to be a pilocytic astrocytoma. Now, how could you tell the difference between this and the pineocytomas? I can't. And so I think the important thing, and I'll bring this up again, I think the important thing for you is to make the distinction between benign and malignant disease. And then when it comes down to the histology, I think the more important decision is to make is whether you think it's if you think it's a meningioma or a metastatic lesion, because these are going to have different behaviors and different treatments. Here's a pineal mass with leptomeningeal enhancement. You can see the carcinomatous meningitis sort of wrapping around the brainstem. So this is not an appearance you'd expect to see with a low-grade pineal cell tumor. This is a pineoblastoma, so a high-grade pineal cell tumor. Here's another one. This adult with headaches, hydrocephalus. I want to point out one feature to you, the fact that you have these peripheral calcifications. These are called exploded calcifications. These are thought to be the normal pineal physiologic calcifications that get displaced as the pineal tumor grows, and it's usually a marker for a pineal-based tumor. And so this is what it looked like on the T2 weighted scan, post-contrast. And this is this, you can see this large, extensive tumor, largely solid. This is another pineoblastoma. So again, high-grade pineal cell tumor. Now, you should also consider tumors of meningeal origin because the tentorial leaves are very close, and tumors of glial origin. Consider metastatic disease in all adults. Here we have another pineal tumor. Now, why is this different than the other cases I showed you? There's another lesion here. You notice this nodule here, here, and this is post-contrast. This nodule did not enhance. This is actually a glioblastoma. So this is a glial tumor involving the pineal region, probably arising not so much from the pineal itself, but from nearby brain tissue. This case has a history of cancer. You can see there's a large pineal region tumor. Notice there's another enhancing focus here. This is an example of metastatic disease. Here's a patient has a pineal region mass. You can see this compression here at the cochlear plate. Pre-gadolinium T1, the lesion is already bright, but not cystic. And so this appearance, and if we know the patient has a history of melanoma and it's enhancing, this is a typical appearance for a melanoma metastasis, that the melanoma mets are either hemorrhagic or the melanin itself can shorten T1 relaxation time. But again, this is a typical appearance of metastatic disease. So something to keep in mind as you're looking at the pineal gland in adults. Now, this one is troublesome in the sense this is the T1 post-contrast scan, and this patient has a history rule out metastasis. But here you can see this nodular appearance of the pineal. Now, we know that normal pineal enhances. So how do I know that whether that's a normal pineal or not? Well, in this case, I was able to look back at the previous scan. This is what the pineal looked like 1 year ago. So this is an example of a pineal metastasis, a small metastasis. And again, because normal pineal gland enhances, you can't use enhancement as a marker, but look for change in size if you have the opportunity to look at previous scans. If you think it looks a little chunky, as this one does, then I would suggest you follow it up. If there's any concern, it could be a pineal metastasis. Now this tumor, again, same location, same sort of property, little bit of inhomogeneous enhancement. What I want to point out to you is that on the CT scan, the calcifications do not have that peripheral exploded sort of pattern. These are sort of intrinsic amorphic calcifications, and this is a meningioma, pineal region meningioma. You notice again, it's low signal on T2 weighted, no restricted diffusion, and here's another one even larger. Large pineal region mass. Notice how homogeneous it is. Homogeneous enhancement. This is what it looks like on the CT scan, kind of a characteristic appearance of a meningioma. So again, use the CT and the MR scan together sometimes, but I do think it's difficult on just the regular MR imaging to distinguish between, as I say, metastatic disease, pineal cell tumors, and glial tumors. There's a lot of overlap in the imaging. Typically, so if you see a typical pineal cyst, the patient has no symptoms and only rim enhancement, personally, I don't recommend follow-up. I know some individuals do. They'll find often something to be a concern about, but I think, unfortunately, we do a lot of unnecessary imaging following these benign pineal cysts. The most important decision you have to make really is whether you think you're looking at a benign pineal mass or not. It's difficult with the malignancies to predict, and so you want to use the history and sometimes CT imaging to try to sort out the exact histology of the pineal region tumor. And that's all I have to say about that subject. I hope you find that useful in your practice. Again, be careful in calling atypical pineal cyst. Recognize that there's a lot of variation in the appearance, and I think you don't want to cause undue alarm in a patient or lead to unnecessary follow-up. Happy to take any questions on that subject. No questions? Well, thank you very much for joining me today.